Yeah. A very good morning, everybody. A very warm welcome to you. A very good afternoon, ma'am. Myself, Aishwarya Nair, welcome you all on behalf of the Pharm D community. Community, I'm thankful to all the participants from all over the country and also from other countries who have taken out time and are attending this morning talk. Pharm D Community has been created with the charter to provide free webinars by eminent doctors and Pharm D doctors. We conduct these webinars solely for the purpose of pursuing interest, facilitate and foster awareness and education in our chosen field of pharmacotherapeutics. Organizing this event wouldn't have been possible without the help of my core committee members. Thanks to Kuldeep, Pooja, Vaishnavi, and Yamini for your support. I'm thankful to the speaker for today, Ms. Gauri Godbole, who is Australia's one of the eminent clinical pharmacists. So I'll hand over the session to Pooja for introducing a speaker for today. Before that, I would also like to tell about our upcoming session on 5th of September. The registration links will be sent in the chat box, so kindly do register yourself before you leave this meeting. So over to Pooja for introducing a speaker for today.
Thank you, Aishwarya. Good morning, everyone. Thank you for joining us today. Our speaker for today is Ms. Gauri Godbole, Team Leader Pharmacist, Aged Care and Mental Health, Gosford Hospital, Australia. Gauri ma'am has been a member of the Society of Hospital Pharmacists of Australia, Geriatrics Committee of Specialty Practice since 2015 and is currently National Chair of this committee. She has over 10 years of experience as a clinical pharmacist, predominantly in geriatric medicine. She is actively involved in activities including the SHPA, aged care seminars, local fall prevention programs, nursing conferences, etc. Since 2013, she has been guest lecturing Masters of Pharmacy students at the University of Technology of Sydney on disease state management, consideration and prescribing in aged care. Board certified geriatric pharmacist embarked on her advancing practice in 2019, gaining her ADVPP credentials. In July 2017, she received the Early Career Pharmacist Award for the SHPA NSW branch. She was honored to be recognized as a fellow of the SHPA in 2019. She has a keen interest in research with publications in Pharmacy Journal. She was selected for the SHPA LEAP program in 2019. Earlier this year, she was seconded as specialist pharmacist to SHPA on short-term assignment to create an advanced training residency program in geriatric medicine. With this introduction, I now hand over to you, ma'am. Over to you, ma'am.
Thank you so much, Pooja, for that really a kind introduction. And thanks, Aishwarya, for the invite. It's just mind-blowing how you guys have taken this initiative and you are welcoming and inviting different, speakers to talk about this really, really important area of medicine, i.e. Embedding pharmacists into taking care of our patients, I guess. I'm just going to try and share the screen now. Excellent. Is everything clear? Can you see my screen?
Yes, ma'am.
Yep, excellent. All right, then. Well, I'll get going. Again, thank you very much. And you guys must be really, really enthusiastic to have woken up bright and early on a Sunday morning to attend, a pharmacy-related lecture. So hats off to you guys. With that introduction, Pooja, just thank you so much. And as Pooja rightly said, I've been practicing as a pharmacist for nearly 10 plus years now. And geriatrics has always been my passion. And I also worked a little bit as an aged care nurse when I was studying pharmacy in Australia. I guess that's where my love affair for geriatrics began. Just very quickly regarding that board certification that Pooja kindly mentioned. This is an American certification. You guys can look it up. It's actually quite fascinating. It's not just in geriatrics, but Board of Pharmacy Specialties in America, they conduct examinations and they credential you with different specialties, like, it could be pharmacotherapy, geriatrics, cardiology, or a whole heap of other things. So you can look it up a little bit later. I guess with new frontiers in pharmacy opening to people, for example, like, what you guys are doing, you're doing Pharm D at the moment, which is in a way new frontier in India at the moment. Pharmacists are making their mark in different other areas, such as being credential dementia practitioners, for example, which I just undertook earlier this year as well. So yeah, it is an honor to present to you guys today. Very quickly, I have no conflict of interest to declare, absolutely none, except I'm very passionate about geriatrics. But all my views are on my own, and they do not represent any organization that I worked for before or I'm working for now. Today, I guess we have an hour and a little bit to talk about a little bit about introduction to aged care, role of pharmacist in particular in a multidisciplinary team, and a typical case study that an aged care pharmacist might encounter. Now, in my earlier conversations with Aishwarya, we have already established, if we were to go in detail with every single ailment that particular patient had, will be here until evening or my night. So I'll be really quickly touching base with what that patient came in on, and we'll talk about it. And I'm happy to, I guess, focus on particular disease state management in future lectures if this goes well. So I would like Aishwarya to actually quickly go through this Zoom poll now, if that's okay, just to understand, or I guess make you understand, why is geriatrics so important, and why do we want to know more about dementia, delirium, postural hypotensions, incontinence, all those things that older adults face. So let's see if that Zoom poll works, Aishwarya.
Yes, so just before the poll, I would just like to inform all the participants that your response will be anonymous. So please give the response, like everybody, please try attempting the poll. Apart from that, usually the poll appears as a full screen, but then still, if you can't see the polls, then try clicking on the upper left-hand corner where you can see a green color button called poll, and then once you click on it, it will be visible on your screen. Yeah, so the poll timing will be for 30 seconds. So I request all my participants to answer the poll immediately as soon as they see it. Yeah,
and
so
you
we'll
get
start.
reminded for any wrong answer, guys. So please answer.
I hope you all can see the questions. It's the last 30 seconds for the poll, so please vote as soon as possible. Yes, ma'am. I suppose you can see the polling results, ma'am.
Yeah, perfect. This is amazing, guys. Thank you so much for answering. And as I said, it's not a quiz that you're going to get reprimanded if you give wrong answer. It's just to create a bit more awareness. So just quickly, I'm going to run through this, and it's great to already see that you guys know quite a little bit about this and understand the importance of knowing more about aged care. I'm just quickly going through the questions. The first one, how often do you think a patient gets diagnosed with dementia globally? And you would be really surprised if I tell you the answer is actually option 4. Every 3 seconds, somebody in this world gets diagnosed with dementia. Now, don't be sad that only 7% of people answered that correctly. When I first looked at it a few years ago, I answered exactly as the majority every 24 hours. The numbers are really staggering. So that's something that, as pharmacists, we can make a really, really good impact and good things for our patients. Second number was total estimated worldwide cost of dementia is huge. I'm not even going to go to that number. I can't even probably spell that number. It's some billions and trillions of dollars, and that's actually true. Most of you have answered that perfectly correctly. It's the disease burden for the patient is huge. However, the burden for, I guess, our society and to put it a bit sadly, it's not all about money, but taxpayers, I guess, it's quite huge as well. Now, just coming back a bit more locally, I guess, and this is a trick question, guys, my apologies. But in India, more than 1 million people have some form of dementia. Of course, the answer is true. But to go in a bit more, I guess, detail, it's not just 1 million people. It's actually 4+ million people in India at this stage have some sort of dementia. And it could be any sort of dementia. It could be Alzheimer's, vascular dementia, or Lewy body dementia or dementia related to Parkinson's disease. And as I said before, I'm more than happy to conduct a later lecture on that. But yes, some form of dementia is prevalent for approximately 4+ million people. That question number 4, delirium is a medical emergency. I'm so happy to say that 81% of you think that it is a medical emergency, and absolutely it is. It's like sadly having an accident or somebody having a stroke and they must be taken to hospital immediately, and that's spot on. It is a medical emergency, and I'm very proud of you guys to get that answer predominantly correct. If dementia were a country, it would be the world 50th largest economy. Actually, what do you think? Like, it's great that you have scored it quite highly, but actually it will be 18th largest economy. So, it will be much more bigger in expenditure wise than we think it is. So it's still good outcome. Like 22% of people think that it's false. That's good. And then there are over 100 different types of diseases that can cause dementia, and absolutely spot on, as majority of you said, that indeed some dementias can be actually typical dementias, or they mimic dementia. For example, some people with B12 deficiency might mimic like dementia-like syndromes. But yes, spot on. I'm really proud of you guys to have answered this. Thank you. I'm going to close this now. So going back to my presentation. Excellent. Now, I'll just, pharmacist role in medication management. I was just hoping to touch base on that a little bit today. When we go up to the wards every morning, and when we look at cases, when we come across diagnoses, we look at pathology and all of that, I guess Yes, all of that is really, really important, but we can play an amazing role in creating an up-to-date medication history to start with. And by that, I mean like knowing about patients' usual medications, which different clinicians they go to. So you must have seen in your practice all the time that a person with, say, rheumatoid arthritis goes to, say, a medical practitioner, or in Australia, we call them general practitioners. So your local doctor, basically. Or they might see a rheumatologist, for example, or they might see an MD medicine specialist person as well. Now, a lot of times what happens is that, doctors or nurse practitioners or pharmacist practitioners, they might be using their own knowledge to perhaps recommend a few things that are required to make the patient's life easier. But the documentation might not be that great. You must truly rely on patients and their families, for example, to understand what medications they really take, for example. So I usually, like if I see a new patient, my first point of call is to get that perfect medication history. And we always forget, well, I must say, medications don't come in a form of tablets, do they? They come in form of eye drops. It might be patches, it might be creams. By patches, I mean medication patches. Say, for example, nospan patch that you have to apply every 7 days, or fentanyl patch. I'm pretty sure in India there might be different other opioids that come in a patch form as well, for example. Those are patches or creams or medications that are kept in the fridge. A lot of times patients totally forget, oh yeah, my thyroxine, that was in the fridge. I totally forgot to tell you I was taking thyroxine. Or a once a week medication, for example, Folitrex or methotrexate. Because it's not taken that often, which is good, people might forget to tell you that they are on it. So an up-to-date medication history is really, really important to even start looking at a case. Of course, our pharmacist role is to individualize the treatment, consider overall needs of the patient and ability to manage that treatment as well. So say, for example, a patient with asthma is on salbutamol puffer, for example, so a metered dose inhaler, for example, and they have arthritis in their hand or wrist. Now, there is no way they're going to be able to actuate that pump and use it properly. So as a pharmacist, now in Australia at least, we get a device called as Halerade. Now that Halerade actually sits on top of a Ventolin puffer or a salbutamol puffer, for example, and helps patient actuate that a bit more easily, for example. So individualizing that treatment in terms of, I guess, devices that you can use, or overall needs of the patient, for example. Then communicating between secondary and primary care. So in our hospital, a lot of times when doctors, actually 100% of times when doctors do their discharge summaries, they come to the pharmacist to have a look at, which is just brilliant because we look at medications from a very specialist view. We all are aware, obviously, if you're not a pharmacy practitioner, as in like nurse practitioners, you may not be able to diagnose an ailment and suggest a treatment for that. But we are certainly trained as medication specialists. So it's really heartwarming. Like, every discharge summary that we look at, we suggest our doctors, hey, we started this patient on a tapering course of prednisolone, for example. Have you got a plan? Have you put a plan in place in your discharge summary for the GP or the local doctor that we only were giving this prednisolone for a gout flare, for example, for 10 days. I don't want it more than that. So those things, we can be a great link in that communication as well. Continuing review of medications, obviously ongoing review of medications. So patients coming in with, for example, I guess a UTI, for example, and they were given just the typical treatment of AMP and GENT, and then the renal function was really, really bad, for example, and you notice the renal function has worsened. for example. So as a pharmacist, you're reviewing the chart and you're like, oh, okay, so what am I going to suggest? Am I going to suggest them to stop the gentamicin, reduce the dose? Can we do a therapeutic drug monitoring, for example, to see if a dose is only required every second day instead of 24 hourly? So I guess that is one of our really big roles as well. Education of patient or carer, this is really, really important. A lot of times patients and carers may not understand all the medical jargon that we use all the time. Like, simple example, just this morning I was talking to someone and not even thinking for a second, I just said GI bleeding. And they were like, what is GI? And I'm like, oh, sorry, that means gastrointestinal bleeding. So that person was not from medical background, had no idea what I was talking about. So it's really important that, we become that link to explain patients their medications and their carers, obviously. And of course, education of other healthcare providers. And by that, I mean, for example, junior medical officers. You can have little education sessions, or you can have education session for nursing staff. Now, there was a very recent education session that I provided for my nurses on the ward regarding antipsychotics, for example. They will touch base on that a little bit in our case. But as to what are the different side effects of antipsychotics, what dose should we be using in older adults if we absolutely have to use it? It's not recommended, but if we have to use it, what do we do? So those kind of education sessions you can provide. You can provide education sessions for students, like we are doing at the moment. That's a big role we can play in continuing the education of other people as well. Just very quickly, medication review approach, for example. So how I look at any case, I guess, is to get a history of diagnosis of or like acute illness. So, for example, why have they come into hospital? Have they come into hospital with a bit of a blood pressure drop, or they have had a fall, for example, those kind of things. Treatment of illness using prescribing principles for older people, which we'll talk in a second. Match the medical history to the medications. Say, for example, they come in with a fall, and then they have a history of hypertension, for example. So, and then they're on 4 antihypertensive medications. So just matching that, obviously. So are these 4 medications that the patient is taking, do they match up with the ailment that the patient has? And of course, you can again do that. A review can take up to 5 hours if you really could afford that much time, but not a lot of time. You have that kind of time on your hands at all. Maximum 20 minutes, 25 minutes. If you're lucky, you might be needing to see so many other patients as well. So matching it to the ailment, and then investigating the mismatches. So I'll give you a classic example of SOMAC or pantoprazole. It's a PPI, proton pump inhibitor. And I see on my med list so many number of times that the patient is on high dose PPIs, like 40 milligrams twice a day of pantoprazole, for example. And you're like, but they don't have a documented history of GORD or gastroesophageal reflux disease. So you obviously then investigate it. And as we know, I won't go again detail into that, but a chronic use of PPIs might lead to whole heap of different things like B12 deficiencies, and it's related to whole plethora of other ailments. So it's good to investigate mismatches. Obviously, check for drug interactions. I won't, you all are very familiar with that. Drug disease or drug contraindications on precautions. Drug administration requirements, for example, as in, how slowly a drug should be given. Now, you can't give IV furosemide, for example, too quickly, because that can cause deafness, irreversible sometimes in some people. So those kind of things, pharmacists can absolutely monitor. Consider ceasing medications with reduced efficacy or higher risk of adverse drug reactions. And again, considering manageability of it. I would like to touch base on evidence-based recommendations now. Obviously, with in geriatrics, a lot of older adults might be excluded from clinical trials because of ethical reasons, or whatever it be. But it's important that we are looking at evidence-based recommendations when we are suggesting therapy in older adults. Look at the long-term goal versus short-term goals. And I just thought I should give you a quick example. As in, they are in hospital, they're immobile, and you're giving a deep vein thrombosis prophylaxis, say DVT prophylaxis with subcut heparin or enoxaparin or something like that. Versus long term. So does this patient have atrial fibrillation? Do they really need to be on a long-term anticoagulation? For example, traditionally with say warfarin or some newer anticoagulant agents such as apixaban or rivaroxaban or things like that. Are there any precautions or contraindications, like this patient falls 10 times a day? Do they really need to be on a long-term anticoagulation? You know, all those kind of things are quite important to think when you actually suggest a medication regime to doctors. And this happens anyway. If you're going on ward rounds, these all things should come up in a discussion regardless. So just the bottom prescribing line, which I always think, and when I was doing my master's, this was almost like grilled into our brains. Every medication taken by a patient must have a clear indication for that patient and must have the lowest ADR or problem possible for that patient. So, of course, we know that, for patient with, say, AF, atrial fibrillation, they need to be on a therapeutic anticoagulation, but this patient falls 500 times in a year, for example. Do they really need to be on that kind of strong anticoagulation? So it's quite important to individualize or rationalize medication management for that particular patient. Now, I'll quickly talk about what strategies we have implemented in Australia, I guess, to improve quality use of medicines in older adults, is clinical pharmacy services, of course. So we have definitely in government hospitals and a lot of private hospitals as well, we have clinical pharmacy, embedded clinical pharmacy services where pharmacists goes on ward rounds, they have their own patients to look after and those kind of things. Enhanced primary care services. So we have GPs or general practitioners or our local doctors, for example, they have their own GP practice pharmacist, for example. So a dear colleague of mine works as a GP practice pharmacist, basically. So he gets referrals from GPs to see I guess patients before they even go and see the GP. So those kind of things, or disease state management programs. And by that, I mean diabetes management, for example, or smoking cessation, all those kind of things. We also have clinical audits. So by 5x5 audits, I mean, that's AMS is antimicrobial stewardship. I'm sure you guys must be familiar with this, with the idea of AMS. And by that, it means that are we treating the right bug with the right drug, or are we using a really, I guess, wide spectrum antibiotics to treat something which can be, which we can use a narrow spectrum antibiotic, and then emergence of resistance, for example, can we afford not to do that? And so we do like audits. Like to the point audits, for example, just on the day, how many patients are on antimicrobials, and do they have, I guess, cultures which should match with with the treatment that they're getting, for example. Education for healthcare professionals, telephone advisory services. So we have great telephone advisory services called as, for example, NPS, National Prescribing Services. They're pretty good as well. And then medication management practice guidelines. So Australian Medicines Handbook, for example, AMH, or therapeutic guidelines, we abide by them, and they're created by expert clinicians, pharmacists, so doctors, pharmacists, social work. Well, they might have some input, but mostly by nurses, doctors, and pharmacists and specialists in their area to create guidelines that we all can follow, basically. So we have spoken about this, but very quickly, of course, offering an up-to-date medication list at discharge. This is of paramount importance, guys. I can't even specify this enough, or the significance of this is that when patients go home, a lot of times they might go home on 3 more medications than they usually are. Hopefully not. But if they are going to get 3 or 4 more medications than they came in on, absolutely important to write down what is the drug, its generic name, its brand name. Obviously, as you know, there's so many brand names of one particular drug that you can, I guess, find in the market. And then what is the strength and how many tablets they need to take, how many times a day, and what to look out for. Like, are there any specific side effects, I guess. And then matching those lists for patient needs, for example, like in India, like it would probably depend on where you work. Like, if you are in a Marathi, I guess, predominantly like language speaking area, you might need to do that in a Marathi language, for example, or from South from South India in different South Indian languages, for example. And again, of course, English, if English is patient's predominant language and they understand it, that is definitely an option to go with. So or that is just the language barrier I'm talking about, but also if the patients can't see. So if they can't see a 12 font Arial, 12 font Word document, you might have to actually increase it to 18 font, for example. So just matching it up for the patient. And then we also have drug dosage administration aids. I'm pretty sure in India I'm going to show you a few pictures. There'll be very similar things that are available as well. I'm pretty sure. You guys tell me a little bit later what kind of things you have up there. And then help with inhalation medication administration. As I said to you before, the Haler aid, you can use some disease management programs that you can link them to. And then medication education counseling, we have already touched based on that. So just very quickly with the dosage administration aids, and this is very, like, it's almost like a pharmacist arena, I guess, they are compartmentalized plastic boxes, for example, like the sets. Now, these are all fancy names for, I guess, even if you have little, trinket boxes and you put Monday, Tuesday, Wednesday, Thursday on it, and they have 2 sections in it, that would do as well. I mean, it doesn't have to be a glorified, I guess, form that I'm talking about, more so like Dosage boxes. Or now Webster pack is it's not. Webster is a trade name of that company that creates those blister or bubble packs. Basically, there are different sachets systems that you can use, or there are other automated medication dispensing devices like tap timers. I'll show you pictures in a second. However, they were originally decided to be used for the carer to supervise medications rather than by the patient. So always remember, you can fix people with any amount of dosettes, Websters, like small trinket boxes of medications to remember. The patient still has to remember taking it. So you can try your best, but still the patient needs to have a certain level of cognitive abilities, I guess, to be able to use these devices. And suitability, that's exactly what I was talking about. Number and toxicity of medications. For example, sodium valproate tablet. Now, those valproate tablets can't go in a Webster pack because they're highly hygroscopic. So the minute you open them from their original blister packaging, they just absorb moisture. So you must be aware as a pharmacist, oh my goodness, can I open these tablets from the original packagings? And of course, the packages itself, is the plastic that we are putting it in, is that toxic to the patient? For example, we can't afford doing that. First, do no harm is our mantra. We must know all these pros and cons before we decide putting things in Webster pack. Medications that are not able to be packed. For example, Pradaxa. Now, I'm not entirely sure if you have a blood thinner up in India, which is called as Pradaxa or Dabigatran. Now, Dabigatran cannot be Webster packed. It is, again, very highly hygroscopic. There are a number of studies that they have done. You have to make sure you keep them in their original packages. They've done studies. You can perhaps keep those packages in the fridge and whatnot. Not everybody might have fridge in their house, for example, as well. So you need to be mindful of those things. cognition of the user. So if they have background dementia, for example, they're not going to be able to use it at all. So you can, as the issue that I mentioned to you guys before, function. So can they remove the medications completely from the device? So sometimes if they again have arthritis of their wrist or whatever, they're not going to be able to do that, for example. And they're not suitable for all patients. They are expensive, or they could be expensive for some patients. And then obviously storage could be an issue as well. We talked about this. So this is what I was talking about, guys. So these are called as Medi sachets or Medi rolls that we get in Australia. So they get packed by a robot, basically, and the patient just takes. So say you can see here, Joe patient. It says take on Friday, the 18th of the 12th, for example, at 9 o'clock. So they just have to open that little sachet and take those medications. Blister packs, they look something like this. You might have seen them before, but on the left hand page you can see it says all the medications that they are on, say pantoprazole, warfarin, rosuvastatin, ramipril, and those kind of things, and exactly that matches what is packed, for example. So they just have to pierce that bubble and take those medications. And this is a tap timer. This is extremely fancy, guys. I hardly see that in my practice as well. They're pretty good for patients with, for example, time-specific medications like Parkinson's medications, for example. So at particular time, that slot just opens and there's an alarm that rings and the patient can just tip their medications and take it, basically. So I just thought I should show you. I don't see them in my practice as they're quite expensive. They're not cheap at all. So just going with the multi-D approach. So just before I proceed, Aishwarya, how are we going for time? Are we okay?
Yes, ma'am, we have time.
Yeah, okay, cool. And again, I can see some hands, raising of hands here. We will keep the questions for later, isn't it?
Yes, ma'am. I've already told them to put their questions in the chat box, and many of them are doing that. So those who are actually raising their hands, I would request them to put their questions too in the chat box so that it can be taken up by the end of the session.
Brilliant. Okay, so I'll continue. So aged care, as I said, is a multidisciplinary approach. Obviously, we as pharmacists just can't be, or in any medicine, I guess, is a multi-D approach. It's not just aged care, but aged care more so. Because it's a holistic approach to medicine. That's how I look it up as, and I'll explain that to you in a second, what I mean by holistic approach. So we have many stakeholders in it. So physicians, nurses, pharmacists, physios, occupational therapists, speechies. So speech pathologists are the ones, as you guys must know, that they assess people swallowing, for example, and might then refer to pharmacists for dosage modification, which I'll explain in a second. Patient carers, social workers, and absolutely last but not the least is the patient. Patients are their, I guess, own advocates and a very important part of their own medication management and healthcare. So nurses, as I said to you, of course, we have nurse practitioners. We know what nurses do. Their role has expanded like anything in recent years, and we absolutely can't do without them as well on the wards. So very, I guess, integral part of aged care. Physicians, as we all know, geriatricians, psychogeriatricians, that's another specialty branch of geriatrics. Of course, they again are an integral part of patient care, obviously. Patient and carers, so it's quite important, as I said to you before, about mentioning their own medications related problems, quite important, because a lot of times we feel like, well, I have observed at least, and even in Australia, that patients, older patients in particular, they don't want to be causing nuisance. They're like, oh yeah, I'm all right, like, that's not a problem at all, that kind of attitude is quite prevalent which is just very hard. I mean, sometimes you're just like, oh no, you're definitely in pain, you should tell us that you are in pain, for example. So they're quite tough kind of people. Older adults are quite tough kind of people. So it's important that they have a voice as well and they feel comfortable raising their concerns. So a non-intimidating approach to talking to them is quite important, devoid of, I guess, medical jargon. And then physiotherapists or occupational therapists, they assess patients for function. So fine, if they go home, are they able to do their dishes, for example? It's as simple as that, but sometimes they might not be able to do that. Do they need extra help, for example? Can they do their own washing and all those kind of things? Speech pathologists, as I said, they assess patients for swallowing difficulties. So a lot of times I get referrals from doctors, our speech pathologist, and the referrals are usually like, hi Gauri, my patient can only swallow minced and moist diet, for example. What medications they can take can be crushed, for example. So then we have different resources available where, or MIMS, for example, is the quickest resource sometimes. You can say, okay, you can't crush this tablet, unfortunately. Then what can we do? Can we give an IV form of that medication until their swallowing issue is resolved? All those kind of things. Dietitians are quite important as well because, for example, with Parkinson's disease medications, levodopa and stuff, you can't give that with protein-rich diet. And then the dietitians can help you saying, oh, look, this feed actually has a lot of protein in it. We have to stop the feed 2 hours before and 2 hours after. Stop the medication 2 hours before and 2 hours after this feed. And then they're like, oh, well, no, they can't stop their Parkinson's disease medication. What can we do? So those kind of things are quite important to be discussed, I guess. Social workers, I won't go too much into detail, but I guess this is more, I can talk about more from an Australian perspective. They identify a whole heap of things like, accommodation, financial services, care stress capacity, all those kind of things. ACAT is the aged care assessment team that can help with accommodation post-discharge, what kind of level of help they need. But this is more so from an Australian perspective. I thought I should just put it up there. And last but not the least, the patient. So if the patient has capacity, and by capacity, I mean they're compos mentis, they don't have any dementia, delirium, they're perfectly fine. It's just that they are frail older people. But if they say to you, look, I don't want you to treat me for this particular ailment. We are like, oh, but say, for example, your cholesterol is so high. And they're like, yes, I know that, but I don't want to be treated for it, for example. I guess there is that merit in respecting patients' choices as well. And that may, I guess, furthermore preserve their independence as well. So it is a complex area. Obviously, we don't want to be missing out on important clinical interventions. But if a patient can make their own decisions and can make choices, then it is prudent to leave it up to them. Discharge planning, of course, it begins at admission, team meetings, having pharmacists, like multidisciplinary team meetings at regular interviews. In our hospital, we have it every day in the morning. Quickly go through each case, I guess. And then, of course, ongoing medication management. What are the cost implications for the patient? I might say that our patient can go on a Webster pack, for example, but it's going to cost them $10 a month. Now, that's a lot of money for some people, for sure. So taking all those things into account are quite important as well. I'll very quickly go through this because this is more so from an Australian perspective. We have here different transitions of care risk assessment forms, for example, which the registered nurses finish they complete it on admission. And that's how they decide whether patients can have, I guess, what kind of services they can have, and go from there. Now, I'd like to quickly touch base on some disease state management principles in geriatrics, as I promised. We call them 5 I's of geriatrics in aged care. So basically, intellectual impairment, immobility, instability, incontinence, and iatrogenic disorders. So all of these are called as geriatric giants, and they are quite multifactorial. Now, I guess first four are quite self-explanatory, but the fifth one I'd like to quickly touch base on is that we are treating, an issue that arises from a side effect of other medication that we're using for other issue. And I guess I gave you a very brief example of that pantoprazole before. So if they're on pantoprazole for a very long period of time, their B12 is really, really low because of that. And then you're giving B12 injections because of that. And then because of B12 injections, the injection site has an infection, for example. You give antibiotics for it, and the cycle continues. This is just a very minor example that I just made up. But this is what I'm talking about by iatrogenic disorders, that we are treating a side effect of a particular drug. Now, do we really need that drug A, which has first caused this issue? Say, for example, pantoprazole again, or a PPI, not just pantoprazole, but any PPI really. Do we really need it in this patient? So having that discussion with the physicians, obviously we have those discussions all the time. This patient doesn't have GORD, or they haven't had GORD for many, many years. They've had reflux issue 20 years ago. Do they still need this medication? Can we reduce the dose? Can we change the frequency of it, for example? All those kind of things. And of course, stopping something cold turkey is not a good idea, obviously. Can we reduce it slowly and then go from there, for example? Now, why is geriatric assessment different to other medical assessments? It's a holistic approach, as I have mentioned to you. We just don't look at any mantra of any disease state management. We just don't look at the numbers, what the pathology is showing us. We actually treat the patient themselves. So it is definitely a holistic approach. We try not to do harm first and start low, go slow with any sort of treatment that we give. There is a thing which you can look it up later. It's called as Comprehensive Geriatric Assessment, CGA. Basically, it focuses on elderly individuals with complex issues. It emphasizes functional status and quality of life, like what are we really trying to achieve in this patient. Sometimes it sounds really, really morbid, I guess, that, is there a real need of giving this medication in this patient, for example. But those difficult discussions must happen between clinicians, of course, taking into consideration patients' wishes and patients' families' wishes if the patient can't make decisions for themselves, for example, and input from multi-D teams as well, of course. So I just thought to put it a bit in a picture form for you. So it's a very, everything funnels down to basically the comorbid disease state, cognition of the patient, and function and frailty. These all complicate care of the older adults basically and lead to major geriatric syndromes. Again, as I said, I would love to discuss these in real detail. But just for now, it's a complex mechanism. The whole management of major geriatric symptoms, it's just not treating comorbid disease, or you're not just treating function and frailty, but you might have like a bit of a trio or some ailment of these all three together, for example, at one given point. I just thought to quickly show you this, which I quite like. It's from NPS, again, medicine-wise. You can look it up later. National Prescribing Services, medicine-wise. If you Google, you'll be able to even sign up for their newsletters and things like that. But if a fit older person, say, has a minor illness of some sort, or has a fall, has a UTI or whatever, their function just drops a little bit, and they might come up to their normal level of independence and go out and about with their lives. But for example, if a frail older person has a similar minor illness, then their functional status might actually dip down to level of being dependent on other people and may not really recover to come up to that independent living. So it's quite important to understand this, that, what kind of patient are we looking at. So frail older people display quite low resilience to minor stressors, like even a fall, like a UTI, or even a mechanical, like a minor fall, for example. I thought this was quite eye-opening when I actually looked at it. Apparently, if you are on 4+ medications, there is a higher, like the incidence of mortality is higher, disability is higher, falls, and even frailty. This was quite eye-opening as well, and this is something that I would really like you to go back and have a look at. It's a nice publication called as Older, Wiser, Safer. And it just sheds some light on polypharmacy, which I'll explain to you in a second, and its effect on different ailments, basically. Now, drug selection principles in older adults, basically prescribing for older, which I will touch base very, very quickly. We'll talk about a bit about polypharmacy and then role in medication management and deprescribing. In older people, of course, the therapeutic response and the toxic response, that window between that is really, really narrow. Again, a very quick example will be of gentamicin, for example. So we treat, adult, fit, older adult people with gentamicin. Say, for example, the kidney functions are great. They're flushing out gentamicin really, really well. But in older adults, the kidney functions are already not that great, obviously, with other ailments that they may have. And giving, I guess, even a little excess dose of gentamicin might do them more harm. So quite important to understand this, that their therapeutic window becomes quite narrow as people age. That's why start low, go slow can be a mantra in geriatrics for some ailments. So we are not treating the person, we're treating the person, not the disease. Obviously, we are looking out for ADRs and drug interactions and polypharmacy or hyperpolypharmacy, which I'll explain to you in a second. So polypharmacy, there are many definitions of it. Any more than usually 4 medications is defined as polypharmacy. Now you'll probably be thinking, oh my goodness, that's like 90% of patients I see. Yes, you're right. And polypharmacy is on increase. One medication taken frequently, that could also be considered as polypharmacy, or basically it's an increased medication burden, for example, for the patient. Classic example would be taking levodopa multiple times. Then hyperpolypharmacy is another term that is emerging. It's taking more than 10 regular medications. The highest number of medications I have seen in a patient, we very ferociously deprescribed a lot of medications for that patient. They came in with, I think, 26 prescribed medications, 28 or something, and we had to look at everything before we could get rid of a few for that patient. But why is there so much polypharmacy? Of course, there's that single disease approach. So rigid application of guidelines. So, or they have this, so we give these 4 medications without thinking about morbidity and mortality of the patient, what their goals are, for example, and their prognosis. Continuation of medications that are no longer necessary. Different specialists, and then they suggest different medications. That happens quite a lot as well. Pharmaceutical company influence, maybe. And then pressure from patients. I think that was really, really interesting. So a lot of times, you go to, patients go to doctors and say, oh, I have this little sniffle, normal cold, not in this COVID world, obviously. Any sniffle will be tested rigorously, but I'm talking pre-COVID world. They just have a little sniffle, like a, I guess, common cold. And the doctor says, look, you don't require antibiotics for this. This is a viral thing. I can't give you antibiotics. And the patient's like, oh, this doctor is not giving me any medications, or that's no good. So obviously that kind of thinking also increases patients' number of medications as well. Clinical implications of polypharmacy, of course, falls, exhaustion, frailty, cognitive impairment, the list goes on. So it's quite important to rationalize their medication plan, of course, to do that in conjunction with patients, families, and that mostly happens on ward rounds. Paradoxically, though, older people using 5 or more medications are more likely to be undertreated than patients taking few medications. That sounds really contradictory, isn't it? But research has shown that if they take more medications, you probably have to pay more attention to as to have we treated all their ailments? Have we looked at all the issues they have? And more likely you will find that not necessarily. They probably were treating an iatrogenic cycle here. This is a quick one, like, as the number of medications increase, the probability of interaction increases. I guess this is a bit of a no-brainer, but it's really good to put that in perspective, that if you're on 20 plus medications, something is going to interact with some other thing. So you're probably going to have 100% probability of interaction there. I just put this together very, very quickly with drug interactions. Apologies, the slide is a little bit whacked, but I'll put that concisely in a second. But people can have drug interactions. For example, Cipro plus olanzapine, causing increased CP and rigidity and falls, for example, or drug-drug pharmacodynamic interactions. So antagonistic action of donepezil and anticholinergic drugs, for example. Drug and nutritional status, so low albumin levels and phenytoin, which can cause increased free phenytoin levels. For example, patient could be confused. Drug herbal products. So I forgot to actually specifically mention, when you ask patients about their medication history, specifically ask about herbal products as well. People forget and they think that, oh, herbal products are not medications. They're absolutely medications, and they interact with a lot of things. So, for example, that ginkgo, I don't know whether we have seen ginkgo in India as much, but say things like garlic, ginger, like, all like, I guess, complementary medications, they may have some or the other form of antiplatelet activity. So check if they are taking aspirin or any anticoagulation with it, which can increase risk of bleeding, and monitor that. Drug and alcohol, for example, benzodiazepines and alcohol would never go well together. And drug disease or drug patient interaction, for example, metoclopramide to be used in Parkinson's disease. Now that's not right. It's a dopamine receptor. It can cause blockade of that. So worsening of Parkinson's disease. So this is literally a snippet, literally, guys, like I could talk about this until cows come home, but this is what we are looking for. This is what we should look out for. Now, all drugs should be used with caution. Obviously, start low, go slow, use the lowest effective dose, simplify the regimen, prescribe from a limited range of drugs, for example, not to complicate the therapy too much. And then obviously there are exceptions. For example, cancer treatments, you have to go aggressive in that, for example. Aishwarya, are we going okay for time?
Yes, ma'am. Like, you can continue and yeah.
Come again?
Yes, ma'am. We are okay with it, ma'am. You can continue with the case study.
Okay, I'll quickly go through this case study. I'm very aware of time, but I'll go through this, so that I can give you a bit of an overview of what kind of cases us as Jerry's pharmacist or aged care pharmacist might come across. Now, again, this is a very tiny snippet, guys, but this is a typical one that we might come across. So this is a real case, FYI. Okay, it's not made up. We had a patient come in, 89-year-old female patient coming in with a fall, with a left neck of femur fracture. So a hip fracture, basically. She was complaining of dizziness and drowsiness and was in atrial fibrillation. Her background was dementia. She had massive mood swings, decreased appetite, ischemic heart disease, coronary artery disease, some sort of vascular disease as well, hypertension, GORD, hyperlipidemia, diabetes, recurrent UTIs, chronic renal failure, anemia, macular degeneration. So she could hardly see, she couldn't see properly, osteoporosis, hypothyroidism, and depression. Again, this is not a made-up case, guys. This is a real one. Her BP sitting down was 140/90. And then we did a standing BP, which was 110/60. And her heart rate was sitting at about 55. Her creatinine clearance, so this is calculated via Cockcroft-Gault formula. I'm sure you guys must be familiar with that, and you use that one in your practice, was about 19 mils per minute. Her vitamin D level was 19. Now, this is, again, I'm going with Australian measurements here, guys. MMSE was 24 out of 30. I'll explain what MMSE is in a second. And then she had allergy to penicillin. It just was a rash that penicillin gave her a bit of a rash. And then she was allergic to inverted comma, to ACE inhibitors, more like a side effect, I guess, of cough. Now, very, very quickly, to explain to you what MMSE is. So, mini mental score examination is an assessment that we can do to assess people's cognition. So, basically, it assesses the degree of impairment and then what effect it can have on day-to-day functioning. The score is from 30. You can have a score from 0 to 30, and 0 is not conducive to life, and 30 is the maximum score you can have. So if you have a score from between 25 to 30, then you may have clinical signs of cognitive impairment, but may have clinically significant or mild deficits in cognition, basically. So if someone's MMSE is between 25 and 30, we kind of sometimes take that with a bit of grain of salt, or repeat it a little bit later as well if the family is saying, oh no, they have bouts of forgetfulness or whatever. It's quite important when that MMSE is done. Now, usually MMSE in Australian practice, at times, pharmacists can be trained to perform MMSE, but this is usually done by doctors as well. So when that score starts going down, for example, between 20 and 25, or between 10 and 20, then between 10 and 20, there is a clear impairment in cognition and day-to-day function, and may require 24-hour supervision, for example. So in our patient's case, her MMSE was 24. Okay, so that's quite questionable what is her baseline. So it's quite important to ascertain what her baseline was. Has that MMSE been performed when she was delirious? Now, you can't perform an MMSE when patient has acute cognitive impairment. That's not going to give you a correct, indication of how cognitively impaired they are. This is her medication list. It's huge, but it is, when I was putting this case together, I've tried to match it with what she has. So risperidone, she was on 0.5 milligram BD for mood swings or agitation. She was also on mirtazapine, not sure, probably for anxiety, some depressive symptoms. She was also on chlorpromazine for mood swings and anxiety as well. Oxycontin, so that's controlled release oxycodone. She was on for it for pain management. Nicorandil, metoprolol, azosorbate mononitrate, diltiazem, all of those medications for her ischemic heart disease, and then aspirin for her as an antiplatelet agent for vascular disease and coronary artery disease, and then a few other things thrown in there for hypertension and chronic renal failure started by a renal physician as well. She had rosuvastatin on board as well for hypercholesterolemia. She was taking cranberry as well for recurrent UTIs, insulin for her diabetes, some Panadol, some magnesium supplements for some hypomagnesemia, sertraline for depression, donepezil, the list goes on. And this was one of the patients we actually de-prescribed a lot of medications for, de-trialed them a little bit as well. But she was also on a concoction of temazepam, and here was chlorpromazine, which was significantly affecting this lady as well. I just wanted to quickly touch base on postural hypotension. Now, if you would have seen this one before, her blood pressure dropped from 140/90 to 110/60. Now, that was quite significant drop from 140 to 110. We explored that a little bit, whether it was a long-standing thing or whether that was because of any medication, or whether because she just was in so much pain, maybe, or her BP was fluctuating perhaps. So I just wanted to touch base quickly on postural hypotension. Now, she was on the risperidone, guys, if you could see that before. That can absolutely cause postural drops as well. By definition, orthostatic hypotension or postural hypotension is when you, if there is a 20/10 systolic over diastolic blood pressure drop within 3 minutes of standing, that defines orthostatic hypotension. So this lady, that's a once-off result. Obviously, you wouldn't go by once-off result and diagnose orthostatic hypotension. You need a bit of a trend to understand it. But this lady, later on, we found out had significant postural drops as well, caused due to age-related changes like decreased baroreflex sensitivity, for example. This all can make older people prone to orthostatic hypotension, basically. And clinical manifestation are due to hypoperfusion or overcompensation, basically. There is not always a correlation between falls in blood pressure and symptoms of orthostatic hypotension. So somebody can have mild drop in their blood pressure, but could still have quite pronounced, implications of that and have falls and things like that. Again, this patient stayed in hospital with us for a very long period of time. The main thing was pain management in this patient. That OxyContin that they were using were obviously not enough. As you guys might know, it's quite important to understand what opioids are okay to be given in renal failure and which one are not, for example. So this lady was initially on morphine. Now morphine gets accumulated in renal failure. So that was stopped, and then she was started on OxyContin. That didn't help her, and there was a huge pain management issue with this lady, which was then fluctuating her blood pressure further. But you can also see there is no charting of any aperients. So this lady was really, really constipated as well. No vitamin D or calcium supplementation. Did she have any, workup for osteoporosis? Is that anemia treated? There were so many questions that came out of that one case discussion. Anticoagulation, does she need ongoing anticoagulation? For example, with warfarin or whatever, not just aspirin. So this is just to show you guys how complex it can get to actually unpack that slowly, one problem at a time, and what is this patient's acute need, and what should we be doing for her on a long-term basis. Does anything need changing for her, like monitoring her blood pressure and heart rate, monitoring renal function, monitoring for delirium, for example? She's at a very high risk of delirium with background dementia. And monitoring of her blood sugar levels, and has an HbA1c been done? Like how does she manage her insulin, for example? She has dementia, so is she giving it to herself, or how does she do it? Then we found out a bit later, mid-stream sample of urine, she was growing UTI. She was growing E. coli, and that was actually causing her acute delirium, and she had temperatures. So then other information that came on board was that she lived in a 2-story house with steps to enter the house. Now, of course, with post-NOF, she's not going to be able to use those steps to get into her house. She was managing her medications with a Webster pack. Now, she said that she was quite compliant with her medications, but obviously we can't be sure whether she was taking them regularly or not taking them regularly. She smokes occasionally, and by occasionally meant every single day, which was obviously not good for her heart. And she drank just socially with family and friends, and her family attested to that. So we were like, okay. Now with urinary incontinence, as you know, she has UTI, obviously. So UTIs can cause acute incontinence in older adults, but I won't again go too much deep into this. But types of incontinences, of course, urge versus stress incontinence versus mixed incontinence, for example. Functional or behavior is very important. Sometimes patients can't just reach the toilet, basically, to use the toilet, and then they are incontinent. So that doesn't mean they are really incontinent. It's functional or behavioral incontinence. And then overflow incontinence. So the many things to think about. A lot of medication she's on, so anticholinergic medications as well. It's important to ascertain that anticholinergic burden as well. So multifactorial incontinence issue basically. And then, of course, with incontinence, we have different non-drug treatments. Every, I guess, incontinence is treated a little bit differently. So for her, we actually treated her with appropriate antibiotics. And this is again taken from Australian therapeutic guidelines. We have to be very careful as to what antibiotic we're choosing, because, for example, we have a lot of E. coli isolates that are now resistant to trimethoprim, for example. So we have to be really careful as to what drug we are choosing, and then look out for sensitivities as well. I just wanted to very quickly touch base on deprescribing. And if you guys have heard that word deprescribing, as to what it is. So it is basically a systematic process of withdrawing inappropriate medications. A very wise friend of mine once had mentioned to me that, how you trial medications for people, you then slowly detrial those medications if the patient doesn't need them anymore. So it's, as I've mentioned to you before, it's not about stopping them cold turkey. You just don't have to stop medications because they're on too many medications, but you have to slowly using a different algorithm. So you can actually just Google even what deprescribing is. There's a monumental amount of literature available out there which can actually explain that to you a little bit. But thanks, guys, for listening to this talk, which has gone a little bit over 1 hour for sure. Yeah, I'm more than happy to take a few quick questions if you have. Otherwise, over to you, Aishwarya.
Yeah, thank you so much, ma'am, for such a wonderful session. Pooja, I would request you to take up the questions if there are any. Actually, the chat box is flooded, so due to time restrictions, we'll be filtering out questions, and that will be asked by Pooja.
Sure. And also, if the need be later, I mean, I'm more than happy to, like, if you want to email me later, that might be an idea. Like, Aishwarya, you can email me and post it or whatever.
Yes, ma'am. I'll do the remaining questions. I'll email it to you so that it can be updated, and then we'll post it on WhatsApp groups and on our social media so that everybody's question is answered.
Sure.
Yes, Pooja. So you can start.
So, ma'am, the first question is, what are the different scales which are available to assess the medications which are used in geriatrics, and which is the best scale to assess the quality of life in geriatrics?
Okay. That's a very good question, whoever has asked it. So we probably might not have different scales as such for, I guess, choice of medication as such. So basically, we go by a few basic rules as to, do no harm first, avoid that iatrogenic cycle, basically. But there are many scales that are available for deprescribing. There are many algorithms you can use, and that's why I was like, if I start putting that in here, we'll be here all evening. So if you guys want to, if you're more interested in prescribing and deprescribing algorithms, I would say every algorithm has got its own merit. So in particular with prescribing algorithms, for example, we have Beer's criteria, stop-start criteria. There are many criteria available, or there is a anticholinergic burden scale that is available as well. However, in my practice, I find that, it's more to... it's very individualistic to the patient, obviously. So we can't say that Beer's criteria says that, for example, we can only use, we shouldn't be using benzodiazepines at all, for example. And now for any particular patient, that might not be a good idea. If they have, say, behavioral and psychological like symptoms in dementia, and they have, say, Parkinson's disease. Now you can't use typical antipsychotics in them. They'll have massive reaction and like extrapyramidal side effects. So benzodiazepines might be the only options for them. For example, again, this is not like a rule as such, but it's very individualistic. But to answer your question, I guess there are criteria like, for example, BS criteria. There's another one called as stop-start criteria, anticholinergic burden index. That such, I guess, those are the ones that pop up in my mind pretty much straight away.
Okay, thank you, ma'am. The next question is, how can we overcome the geriatric patients' perception that they are being over-medicated? Like, how do we counsel them?
That's a really good one. So that's again a very good question, guys. So how I look out for it is that, in my practice, I usually, when I go and counsel my patients, I usually go with a medication list, basically. So spot on, whoever asked this question, is that a lot of them are like, oh, I'm not going to take this medicine at all. And you're like, okay, well, what is the reason for it? Like, did you have any side effect with it? Or is it just that you just don't want to take your medicines, basically? That could be a very legit reason that they don't want to take it as well. Other thing to remember is that we can't really force people to take medicines. Yes, I get it that they're coming to hospital every month because they are non-compliant to their medicines. But that's when, carers come into picture. Like if they have people looking after them to perhaps take the control of their medicines. But a lot of people who have, I guess, capacity to understand really why they don't want to do it, they don't want to take their medicines. A very important factor we actually fail to understand a lot of times is finances as well. A lot of people might not be able to afford medications as well, which is really, really sad, but that could be the reason why as well. But I usually tend to address it with a list of medicines. So if they're getting discharged with, say, 5 medicines, I take a list with me and explain to them what each medication is doing to them. And also a very important thing to remember is that they have that power to go to their doctor and perhaps also not in a nefarious or mean way but perhaps just request clarification as to how long am I supposed to take this medication for, because some people might have that perception, oh my goodness, this is going to stick with me for the rest of my life maybe. But that might not be necessarily the case.
Okay, thank you, ma'am. One more question we have received is, in geriatric patients, nutraceuticals play a vital role and they are as effective as allopathy. So do they have any side effects?
Sure. I must be very honest with you. I personally don't have much experience using, I guess, nutraceuticals as such. So I wouldn't be, I guess, the best person to discuss about them. But I feel that, there is a merit in thinking laterally. Like, thank you for asking this question, actually. So there is always a merit in looking at I guess nutritional demands and whether that is going to affect a patient's overall care or not. Now, I would, as I said to you, I'm not probably an authority in discussing that, but I feel that, anything that patient takes, herbal medications, nutraceuticals, or anything, or any alternative medicine, like in homeopathy or Ayurvedic medications, absolutely look out for interactions with allopathic medications because Ayurveda has been practiced in India for thousands of years. Obviously, there is a merit, and some people absolutely vouch by it. So, rather than completely dismissing any branch of medicine, I usually look at it again a bit more holistically as to, is there a documented interaction that patient might have with taking these alternative medicines with allopathic medicine. And if the research is showing that no, there is no significant interaction, then perhaps discussing that with patients, carers, and with prescribers is really, really important.
Yeah, thank you, ma'am. Probably this is the last question now. How do we calculate the doses in the geriatric patients, and does the calculation of the dose depend upon the patient's past medical history, or is it given just based on the current clinical condition?
Brilliant, guys! You asked so nice questions. I'm so proud of you. So basically, it's multifactorial again. So it will depend on patients' past medical history as well as what's happening to them acutely as well. And I would again perhaps go to what's a good example to give. For example, mm, just trying to think a really good example that we look at all the time. Say again, renal function. I guess renally cleared drugs. Again, that's a really good example. Say for example, your patient has no issues with their kidney function. Their renal function is fine usually. So what is their baseline? So to ascertain what their baseline is quite important. But then you realize that they have got acute renal failure at this stage. So why is that acute renal failure happening? Have they not had enough water? Are they dehydrated? Are they're having a UTI, for example, and that's why they're going urinating quite a little bit? Are they on any medications which is causing a lot of diuresis? All those kind of things are quite important. But understanding, is this an acute renal failure or it's a chronic renal failure? Now some people can have acute renal failure on top of chronic renal failure. So they say their baseline is about 30 mils per minute, for example, and at the moment they come to you to hospital with a renal function of say 20 mils per minute. Now you will obviously look at their long term renal function or their chronic renal function. But at this stage, because their renal function is about 20 mils per minute, what are the dosing adjustments that I need to suggest, so that when they go to their usual 30-35 mils per minute, can we then reverse our decisions? A great example for that would be DOACs, or direct oral anticoagulants, or newer oral anticoagulants like Epixaban or rivaroxaban. Patients, say rivaroxaban, their usual renal function is about 60 mils per minute. They're on a normal or whatever 20 milligram dose of rivaroxaban for their AF, but they come to hospital with an acute renal failure and their renal function is now sitting at say 40 mils per minute, say. Then you might suggest to your team to say, hey, look, the renal function has deteriorated a little bit. Would you like to reduce the dose to 15 whilst they're in hospital? And then we'll monitor how they go. And perhaps at discharge, we'll monitor again and suggest the GP, local doctor, to monitor it further and bring it back up to 20 if the renal function gets better. Have I answered that? Have I answered that question?
Yes, ma'am. Thank you so much. And yeah, thank you so much. That was really a very informative session, and it surely added so much to our knowledge regarding the management of the special population that is geriatrics. Thank you once again.
Not a problem. Thank you so much, guys. Apologies for the initial, I guess, hiccups with technology, but now I know how everything works, and hopefully I was able to, I guess, shed a little bit of light into what is a really, really complex and vast area to talk about in our.
Yes, thank you so much, ma'am. With this, I would hand over to Pooja to please propose the vote of thanks.
Yes. On behalf of the Pharm D community, I want to thank our speaker, Ms. Gauri Godbole ma'am, for such an informative and enlightening session. I'm sure that this session will be useful for all the clinical pharmacists. Want to thank you. I also want to thank you, ma'am, for taking time out of your busy schedule and in this pandemic to deliver us this lecture. I hope that you will come back again for another lecture. Uh, and I also want to thank all the participants for coming to for joining this webinar on the Sunday morning. And the link for the feedback form is posted in the chat box. Please do fill it, and the link for the next webinar is also posted. Thank you, ma'am.
Thank you so much. Thanks, everybody. Thanks, Aishwarya, Pooja, and the other two organizers. My apologies. Kuldeep, I could remember, I think, and sorry, I couldn't remember the fourth one. Thank you so much, guys. You're doing a great job, and more than happy to participate again as well, hopefully, depending on the feedback. Thank you so much, guys. Have a good one.
Thank you, ma'am.
Bye-bye.
Thank you, ma'am.
Thank you so much, ma'am. Bye,
No
ma'am.
worries. Bye-bye. Bye.